We usually think about medicine in terms of, um, well, what it allows us to do, right? We think of it as this purely additive process.
Right, yeah. It's supposed to give something back to you.
Exactly. Like you tear a ligament, a surgeon goes in and repairs it, and the intervention gives you your mobility back.
Yeah.
Or you get a bacterial infection, you take an antibiotic, and the medicine clears the bacteria so you can go back to functioning normally.
You're restored to your factory settings, basically.
Yeah, factory settings. That's a great way to put it. The baseline assumption, really, the entire cultural narrative around healthcare, is that medical intervention restores a freedom that was temporarily lost to, illness or injury. I mean, medicine opens doors.
It's the dominant paradigm, definitely.
Right.
We look at healthcare as a restoration of agency.
Right.
And because of that, our expectations of medical communication are completely conditioned to anticipate the positive. Like, we expect to read about efficacy rates, about how quickly a drug acts, about the return to
We
normalcy.
want the good news.
We only want the good news. We are highly trained to view the physician as the person who just hands us the key to unlock whatever door the ailment has shut.
Which is exactly why the source material we are pulling apart today is just, well, it's so jarring.
Oh, it really is. It caught me completely off guard.
Right. So for you listening, we are looking at a very specific, fairly brief excerpt from an article published on Medical DOC, and that's a Japanese medical media site.
Yep, and it's important to note how this got out there.
Exactly. This piece was distributed through Smart News, and it's critical to note right up front that this is doctor-supervised content. It's public-facing, sure, but it's carrying the weight of actual medical authority.
Which completely changes how you have to read it.
Totally. It's exploring the treatment of ADHD.
Mm.
But the angle it takes, like the actual hook used to bring the reader in it, completely flips that script of medical liberation we were just talking about.
It does. It goes in the exact opposite direction.
It really does. The title, when translated, asks, and I'm quoting here, do you know there are things you won't be able to do by taking ADHD medication?
It's a remarkable framing choice. I mean, the immediate focus isn't on the restoration of focus or the calming of hyperactivity.
Right. There's no mention of feeling better.
None. The entry point to the entire discussion is restriction. It leads with the concept of a closed door instead of an open one.
I have to admit, my initial reaction to reading that headline was just skepticism.
Really? Like you thought it was clickbait?
Totally. When you see a digital media headline highlighting the negative aspects of a common medication, focusing on what you won't be able to do, it smells a little bit like clickbait to me.
Oh, I can see that. The internet is full of that kind of stuff.
Yeah. It feels like a fear-mongering tactic designed to generate clicks by scaring people who are, either taking the medication or maybe considering it. So I have to ask you, why are we treating this as a profound piece of medical communication rather than just like a savvy editorial trick to drive traffic?
Well, it's a completely fair question. And the tension between media strategy and medical communication is very real. But, and this is key, you have to look at the context of the platform.
Okay, lay it out for me.
This is doctor-supervised information aimed at the general public. In that specific arena, every single word is heavily vetted for liability and accuracy.
So they can't just be throwing stuff out there for clicks.
Exactly. If a medical professional is signing off on a headline that leads with restriction rather than relief, it suggests a really deliberate philosophical stance on how patients should approach pharmacotherapy.
So it's not an accident.
Not at all. They are aggressively front-loading the concept of trade-offs. It's an assertion that true medical literacy requires grappling with the cost of an intervention before you even get to discuss the benefits.
Wow. Okay. So whether you listening are personally navigating a neurodevelopmental diagnosis or, you're just fascinated by the psychology of medical communication, or you simply want to examine how we as a culture define a solution, we're going to tear this excerpt apart today in this deep dive.
And there is so much to tear apart.
There really is. Because beneath this seemingly simple, slightly provocative headline is a surprisingly radical framework for understanding human behavior, the environments we force ourselves into, and the actual psychological cost of chemical intervention.
It's a heavy lift for one little headline.
Yeah, no kidding. But before we get to the restrictions the medication imposes, we have to look at how this doctor-supervised text actually defines the condition it's trying to treat.
The definition is really where the philosophy starts to reveal itself. I mean, the text states that ADHD is a disorder characterized by inattention, hyperactivity, and impulsivity.
which are the standard clinical markers,
Or
right?
exactly, those are the standard markers.
Hmm.
But the defining feature, the actual thing that elevates those traits to the level of a disorder, is explicitly described as their impact on, quote, daily life, such as school life and work.
Okay, let's stop right there,
Yeah,
because this is the pivot point of the entire discussion.
it really is.
I mean, inattention, hyperactivity, and impulsivity are human traits. They exist across a massive spectrum. We all experience them to varying degrees.
Of course. Everyone has days where they can't focus.
Exactly. But this medical text doesn't just say, oh, it's a neurochemical imbalance. It explicitly anchors the pathology to the individual's friction with school life and work. It ties the biological condition directly to societal institutions.
Which fundamentally challenges how we normally think about illness. Think about it. If you have a ruptured appendix, it's a medical emergency, whether you are sitting in a boardroom, sitting in a classroom, or stranded alone on a desert island.
Right. The location doesn't matter. Your appendix is still bursting.
Exactly. The pathology is entirely internal and biological. But the framing here suggests that the pathology of ADHD is at least partially contextual.
Contextual, meaning it depends on where you are.
Yes. The traits themselves are internal, sure, but the disorder is the collision between those internal traits and the external demands of highly specific, rigid environments.
But wait, isn't that just a pragmatic way of explaining it to a general audience? Like, you say the text is anchoring the pathology to the institution, but maybe the doctor supervising this just used school and work as the most, I don't know, relatable examples of daily life.
That's a valid way to interpret it, but I think it goes deeper.
Because, I mean, if your impulsivity causes you to ruin a personal relationship, or your inattention causes you to get into a car accident on the weekend, it's still a disorder, regardless of whether you're at the office. I guess I just want to push back on reading too much anti-institutional philosophy into a simple media summary.
I wouldn't necessarily call it anti-institutional, but I would absolutely call it ecologically aware.
Ecologically aware. Okay, I like that term. Tell me more about that.
Well, let's look at the mechanics of what a diagnosis actually requires in practice. A diagnosis of a mental health or neurodevelopmental disorder typically requires that the symptoms cause clinically significant impairment in social, occupational, or other important areas of functioning.
Right, it has to actually mess up your life.
Exactly, and the Japanese text here is highlighting the occupational and academic spheres as the primary arenas of impairment. Why? Because those are the environments with the narrowest bands of acceptable behavior.
Oh, that makes so much sense. They're the environments with the least amount of elasticity.
Precisely. If you are highly impulsive or inattentive in your social life, you can organically select friends who find your high energy charming, right? Or who just don't mind if you change the subject rapidly.
Yeah, you just surround yourself with other high-energy people.
You curate your social environment to accommodate your traits, but you can't curate the structural demands of a corporate office or a university lecture hall.
Definitely not. You have to sit there and listen.
You are forced to operate within a system that demands prolonged, static attention and suppressed physical movement. So the text, explicitly citing school life and work, acknowledges that the friction is highest where the environmental elasticity is lowest.
Okay, that makes a lot of sense. It's not that the suffering isn't real outside of those places. It's that those places are the ultimate stress test for this specific set of neurological traits.
The ultimate stress test, that's perfect.
It's like, okay, think of it like taking an off-road vehicle and trying to race it on a Formula One track.
Oh, I love a good analogy.
Right, the vehicle isn't broken, the suspension works perfectly, the engine is super powerful, but it's going to fail on that track because the environment demands a completely different set of specifications. The disorder in this analogy is the attempt to race the Jeep on the asphalt.
And that leads directly to the question of how you solve that friction. If the disorder is the collision between the brain and the environment, where do you intervene?
Do you modify the vehicle or do you change the track?
Exactly. And this is where the text introduces its treatment triad. And I have to say, the sequence of that triad is just fascinating.
It really is.
Yeah.
So the text outlines a three-part approach to treatment. It says, and I'll quote it directly, ADHD's treatment includes, in addition to devising ways to arrange the environment and psychotherapy, pharmacotherapy.
The syntax there, we really need to look at the syntax.
I want to look at exactly that because as we established, this is highly intentional communication. It lists devising ways to arrange the environment and psychotherapy first.
Yes.
And it positions pharmacotherapy medication as the additive element. It's literally phrased as in addition to the other two.
Which is huge.
It really runs completely counter to the prevailing cultural narrative, especially in the West, where the pill is viewed as the primary intervention. And, maybe you get some coaching or therapy on the side if you have the time and money.
It's a profound decentralization of medication. By devising ways to arrange the environment as a co-equal primary pillar of medical treatment, the text is validating external adaptation as a core medical strategy.
It's medicalizing the act of changing the world around you.
Yes, which is such an empowering way to look at it.
But I struggle with the practicality of that, though. I mean, devising ways to arrange the environment sounds incredibly empowering in a theoretical article.
Sure, on paper it sounds great.
It sounds great to say, change the environment, don't just change the brain.
Hmm.
But the reality of school life and work, the very environments the text called out, is that they are notoriously hostile to individual arrangement.
They are built on conformity, yeah.
Right. A student can't just arrange their high school to let them walk around during a calculus exam.
Yeah.
An entry-level employee can't just arrange their open-plan office to be a sensory deprivation chamber.
Right, you can't just knock down walls.
Exactly. So isn't prescribing environmental arrangement just placing an impossible burden on the patient to fight immovable systems?
It can be, absolutely, if the burden is placed solely on the individual. But by classifying it as a medical treatment, supervised by a doctor, it transforms environmental arrangement from a personal preference into a medical necessity.
Oh, I see. So it's the difference between asking for a favor and having a doctor's note.
Precisely. If a doctor says, this patient requires a modified workspace, it carries a completely different weight than an employee just saying, I prefer a quiet desk.
That makes sense. It leverages medical authority to force the institution to bend.
Yes, but to address your skepticism about practicality, because it's a very real concern, arranging the environment doesn't always mean dismantling the entire corporate structure.
Okay, so what does it look like in reality?
It's about auditing the friction points. So if the clinical trait is inattention and the environmental friction is auditory distraction, arranging the environment might be as simple as the sanctioned use of noise-canceling headphones.
Okay, that's pretty accessible.
Right. Or shifting the hours of deep work to times when the office is empty. If the trait is hyperactivity, it might involve getting a standing desk or building in structured microbreaks.
So it's not always a massive overhaul.
Not at all. The significance here isn't the scale of the arrangement. It's the philosophical assertion that the environment is malleable and modifying it is a valid, recognized medical intervention.
It shifts the locus of the problem. Like, if the treatment is arranging the environment, it implies that the environment itself was at least partially flawed or at least ill-suited.
It takes the blame off the person's brain.
Exactly. It absolves the individual from carrying 100% of the pathological blame.
Exactly. It validates the individual's experience. It basically says, your brain is struggling because this environment is objectively difficult for your neurotype. Let's fix the environment first.
I love that. Okay, so then we move to the second pillar, psychotherapy. How is psychotherapy functioning in this specific triad?
It's a great question because it's not what people typically think of.
Right, because usually we think of therapy as a place to unpack trauma or deal with anxiety. How does it act as a primary intervention for traits like hyperactivity or inattention, alongside, moving your desk to a quieter corner?
Well, if the first pillar, arranging the environment, is about reducing the external friction, the second pillar, psychotherapy, is about building the internal architecture to handle the friction you cannot escape.
Because like we said, you can't arrange the whole world.
Exactly, because you were right earlier. You cannot arrange the whole world. Environments will inevitably be hostile or rigidly structured. Psychotherapy in the context of ADHD often leans heavily into cognitive and behavioral strategies.
So it's less lying on a couch talking about your childhood.
Way less. It's less about unpacking childhood trauma and more about executive function training.
So it's tactical.
Highly tactical. It's about metacognition.
Metacognition.
Yeah.
Thinking about how you think.
Yes. Learning how your specific brain operates. If you know your impulsivity spikes in high-stress meetings, psychotherapy provides the internal scripts and behavioral speed bumps to manage that impulse in real time.
Oh, that's interesting. So it's like installing software patches.
Exactly like that. If you know your inattention makes large projects paralyzing, therapy is where you learn the cognitive frameworks to deconstruct those massive projects into microtasks. It's really about building a custom user manual for a unique operating system.
Which makes perfect sense as a complementary system. You arrange the environment to remove, say, 40% of the friction, and you use psychotherapy to build the internal resilience to navigate the remaining 60%.
And that brings us to the third pillar, the one that the article ultimately focuses on: pharmacotherapy, medication.
In addition to the first two.
Yes, the syntax is crucial there. Pharmacotherapy is introduced as the chemical modulation that sits on top of environmental and psychological adaptation.
It's the final layer, not the foundation.
Right, because think about it. If you only take the medication, but you haven't arranged your environment or built your internal cognitive tools, you might have increased focus, sure.
But you're focusing on the wrong things.
Exactly. You won't necessarily have the architecture to direct that focus productively. You might just become intensely hyper-focused on entirely the wrong things because the environment around you is still chaotic.
Okay, this brings us to the actual hook of the article, the most provocative piece of this whole text.
Here we go.
We've established this beautifully holistic, three-pronged approach. You tweak the environment, you build the internal tools, and you use medication as the final piece of the puzzle. But when the article actually zooms in to discuss that medication, it doesn't talk about how well it works.
Nope.
It doesn't celebrate the relief it brings. The text literally says, in this article, we will explain the side effects and points to note that may occur with ADHD medication.
It just cuts right to the chase.
It does. And it leads with that incredibly sharp headline, did you know there are things you won't be able to do by taking ADHD medication?
It's just so striking.
So let's really interrogate this, because even if we accept that this isn't just clickbait, it is still a really jarring way to educate a patient.
It definitely breaks the mold.
Right. When someone is seeking medical help for a condition that is disrupting their school life and work, when they are actively failing or really struggling in those rigid environments, why would a doctor-supervised text choose to emphasize the new limitations that treatment will impose?
You're asking why they would risk scaring them off.
Exactly. Doesn't that risk discouraging someone from a treatment that could potentially save their career or their academic life?
It absolutely risks discouraging them, and that is entirely the point.
Wait, really? You think the explicit goal is to discourage pharmacotherapy?
I think the goal is to prevent unconscious pharmacotherapy. We have to look at the psychological transaction of taking a psychotropic or neurostimulating medication.
The transaction, I like that word for this.
Because it is one. The text is forcing the reader to acknowledge that medication is not a unilateral enhancement. It is an exchange.
You're trading one state for another.
Yes. You are sacrificing a known baseline for an engineered baseline. And engineered baselines come with maintenance costs, structural weaknesses, and operational restrictions.
Maintenance costs. That's a powerful way to frame it.
By leading with things you won't be able to do, the medical platform is enforcing a radical, almost aggressive form of informed consent.
Okay, I want you to unpack radical informed consent, because standard informed consent, for most of us, is just the pharmacist handing you a folded up piece of paper with a list of side effects printed in microscopic font that you immediately throw in the trash.
Right, or click accept without reading, exactly. Standard informed consent in modern medicine is often treated as a legal shield. It's a liability waiver.
Like, hey, we warned you it might cause dry mouth, so you can't sue us.
Exactly. It's the guy talking really fast at the end of the commercial. But radical informed consent, which is what this article is attempting by putting the restrictions right there in the headline, elevates the trade-offs to the primary criteria for making the medical decision.
So it's not a footnote anymore.
It's the main text. It tells the patient, do not evaluate this medication based purely on its potential benefits. You must evaluate this medication based on your willingness to tolerate its restrictions.
So what are these restrictions? The text actually mentions two distinct categories. It says side effects and points to note. Let's differentiate those, because I think we colloquially use those terms interchangeably, but a medical text wouldn't, right?
Oh, absolutely not. They are distinctly different categories of limitation.
Okay, let's start with side effects.
Side effects are the physiological or psychological tolls exacted by the chemical agent itself. They are entirely involuntary reactions.
So things your body just does in response to the drug.
Right. The medication modulates dopamine or norepinephrine to improve your attention, but that exact same chemical modulation might simultaneously suppress your appetite, elevate your heart rate, or disrupt your sleep architecture.
So in the context of the headline, things you won't be able to do, a side effect means you literally might not be able to sleep at 10 p.m. anymore.
Yes.
You might not be able to eat a full meal at noon because you're just not hungry.
Exactly. The drug gives you the capacity to sit through a 3-hour meeting, but it strips you of the capacity to regulate your physical needs naturally.
Okay, so it is an involuntary biological compromise. You are trading neurobehavioral freedom for physiological disruption.
That's a perfect summary of the side effect. But the second category, the points to note or precautions, is where the concept of restriction gets even more fascinating to me.
Why is that?
Because these aren't involuntary biological reactions, these are behavioral mandates.
Mandates, meaning
Yes.
rules you have to follow just because the chemical's in your system.
Exactly. Pharmacotherapy requires compliance. Points to note usually translate to strict behavioral limitations.
Like what? What kind of rules?
Well, depending on the medication, you cannot consume alcohol. You cannot mix this with certain over-the-counter cold medicines. You cannot take it at irregular hours.
You have to be rigid about your schedule.
Very rigid.
Mhm.
And you cannot suddenly stop taking it without risking severe withdrawal or a massive rebound effect.
Or, you might not be able to operate a vehicle or heavy machinery during the titration phase while your body gets used to it.
Right. So the medication doesn't just act on you, it requires a really rigid partnership from you. It imposes a level of structure on your life that you absolutely must adhere to in order to maintain that engineered baseline safely.
Which is deeply, deeply ironic.
Isn't it?
Think about it. We established earlier that the primary struggle of ADHD, the thing that defines it as a disorder, is the friction between the individual's traits and the rigid, structured demands of school life and work.
Right. The inability to conform to rigid rules.
Exactly. The person is struggling because they can't conform to the rigid rules of the external environment. So the proposed solution, the pharmacotherapy, is to introduce a chemical that imposes an entirely new set of rigid biological and behavioral rules.
It's wild when you look at it that way.
You are literally trading the external rigidity of the workplace for the internal rigidity of the medication protocol.
That is the ultimate trade-off. And it's exactly why the Japanese text's framing is so brilliant. It highlights the inherent irony of the whole intervention.
You are escaping one form of restriction by adopting another.
Escaping one box to get into another box. And this is why placing the things you won't be able to do in the headline is actually a profound act of medical respect.
Respect. How so?
Because it treats the patient as a complex arbitrator of their own life. It asks them to weigh two different types of friction.
It's giving them the agency to choose.
Yes. It asks, is the chaos of your unmedicated baseline and the friction it causes at work more intolerable than the rigid behavioral compliance and physiological side effects demanded by the pill?
It's asking the patient to choose their preferred form of difficulty.
Exactly. Choose your heart. And the subtext here, especially when you consider it alongside the other two pillars of treatment we talked about, is that maybe for some people, the cost of the medication is just too high.
They might look at the balance sheet and say no.
Right. If the medication means you can't sleep, you can't eat normally, and you can't enjoy a glass of wine at dinner with your friends, the patient might look at those restrictions and say, you know what, I would rather deal with my impulsivity.
I'll just try harder to arrange my environment.
Exactly. I would rather just work harder on arranging my environment and going to psychotherapy because the cost of this chemical compliance is actually worse for my quality of life than the disorder itself.
Okay, I hear that, but I want to push back on that slightly, though.
Go for it.
By making the restrictions so prominent, doesn't it minimize the absolute devastation that unmanaged ADHD can cause?
That's the danger, yes.
Right, because I get the philosophical elegance of choosing your preferred friction. That sounds great in a podcast studio.
Yeah.
But for a lot of people, the unmedicated baseline isn't just, oh, I have some friction at work.
No, it can be catastrophic.
It's job loss. It's academic failure. It's profound depression stemming from an inability to execute basic, everyday life tasks. When the stakes are that incredibly high, harping on the fact that you might not be able to drink alcohol or that your sleep might be disrupted feels almost luxurious.
It feels privileged.
Exactly. It feels like a philosophical exercise that ignores the immediate burning crisis of the patient.
That is a critical counterpoint, and it's actually the exact reason why this content is doctor-supervised.
How does that change it?
Because the text isn't suggesting that the restrictions outweigh the benefits for everyone. It's not anti-medication. It is simply ensuring that the crisis doesn't blind the patient to the reality of the intervention.
Blind them to what they're signing up for.
Right. When someone is in the crisis state you described, facing job loss, facing academic failure, they are highly, highly vulnerable. They are desperate for the magic pill.
They just want the pain to stop.
They are desperate for the door to be opened. If a medical provider just hands them the medication and focuses solely on the relief, they are setting the patient up for a secondary crisis when the side effects inevitably hit.
Because the patient wasn't prepared for the cost. They thought they were just getting fixed.
Precisely. If you are drowning and someone throws you a life preserver, you grab it immediately.
Of course.
But if that life preserver is covered in thorns and no one warned you about the thorns, your immediate reaction might be to let go of it out of shock and just drown anyway.
Oh, wow. That's a visceral image.
By leading with the thorns, by explicitly stating, here are the things you won't be able to do, the medical text is trying to prevent treatment abandonment.
So they don't just throw the pills away after week 1.
Exactly. It's saying, this medication will save your job, but it will cost you your appetite and demand strict routine. Accept the cost before you take the pill. That isn't minimizing the crisis. It's building a sustainable, long-term response to it.
It's managing expectations at the most fundamental biological level.
It's also forcing a broader cultural conversation about what we even consider a cure. We live in an era of hyper-medicalization.
Oh, for sure. There's a pill for everything.
Right, where the immediate impulse for any deviation from the norm is pharmaceutical intervention. The framing of this article acts as a speed bump for that cultural impulse.
Let's look at how all these pieces fit together, because this extremely brief text has essentially given us a complete blueprint for how to view neurodevelopmental management.
It really packs a punch for such a short excerpt.
It does. We started with the definition. The text didn't define ADHD in a vacuum. It defined it by how the traits of inattention, hyperactivity, and impulsivity collide with the rigid frameworks of school life and work.
Right. It established that the disorder is deeply, inherently intertwined with the environment.
And because the disorder is intertwined with the environment, the treatment must also address the environment, which is why the text established the triad of care.
The 3 pillars.
Right. It elevated devising ways to arrange the environment and psychotherapy to primary interventions, and framed the chemical modulation of the brain pharmacotherapy as an additive measure.
And then when it finally discussed that additive measure, it bypassed the benefits entirely to focus on the restrictions.
Things you won't be able to do.
Side effects. Precautions. It shattered the illusion of the magic pill and replaced it with a transactional reality. You are trading one set of problems for a more manageable but highly regulated set of limitations.
It is a masterclass in shifting the narrative of care. I mean, it moves the patient from a passive recipient of a fix to an active negotiator of their own biological and environmental reality.
Active negotiator. I love that phrasing.
It just makes me think about how much energy we spend trying to force ourselves into boxes that weren't built for us,
So much energy.
and how eager we are to take a chemical just to make that box feel slightly more comfortable.
And that is exactly the thought I want to leave the listener with today.
Give it to us.
We spent a lot of time analyzing that first pillar, environmental arrangement. We recognize that the medical establishment, at least in the context of this Japanese text, views the modification of your external world as a valid, necessary treatment.
Modifying the world, not just yourself.
Right. So if we accept that a major component of the disorder is the friction between the brain and the rigid institutions of school life and work, and if we understand the heavy physiological and behavioral costs of taking medication just to survive in those institutions, we have to ask a deeply uncomfortable question.
What's the question?
How much of our reliance on these medications and our willingness to endure their side effects and restrictions is driven entirely by our society's absolute refusal to build more elastic environments?
Oh, man. That is the question, isn't it?
If we are willing to mathematically engineer a chemical to alter the baseline functioning of a human brain just so a person can sit at a desk for 8 unbroken hours, shouldn't we be equally willing to ask if the 8-hour desk requirement is the actual pathology?
That is such a profound flip of the perspective.
So I invite you, listening to this deep dive right now, to audit your own friction.
Look your own life.
Exactly. Look at your workplace, your classroom, the daily routines you force upon yourself. Ask yourself, is this environment designed to support the way my brain naturally operates?
Or am I fighting it every step of the way?
Right. Ask yourself, am I continuously paying a chemical, psychological, or emotional cost simply to tolerate an architecture that was never built for me in the first place?
Sometimes the most profound medical intervention isn't figuring out how to survive the friction. It's recognizing that you have the authority to remodel the workshop. For everyone listening, until next time, keep diving deep.